Highlands News Talk 730 presents The Medical Hour, brought to you by Florida Hospital Heartland Medical Center. Now, here's your host, Peter Bloom.
Well, good morning, everyone. Hope you're having a great day today and have a wonderful weekend. Sounds like I'm signing off, but I'm not. This morning, my guests are Michael Latzko. Good morning, Michael.
Morning, Peter.
And
thanks for having me.
You're very welcome, and you are a board-certified, fellowship-trained general surgeon.
That's correct.
Okay, and we have Kat Muse. Good morning.
Good morning.
And you are you now the office manager, or you're going to be the office manager?
I'm going to be.
Okay, and when do you start that?
I believe towards the end of November.
Oh, okay. Mm-hmm. All right. Well, what I'd like to do is start with you, Michael, and that is give us a little bit of your background.
Terrific.
Where you're from, how you got to where you are now.
Well, I'm originally from Los Angeles, but I did most of my training in the New Jersey and New York area. I did my residency at a place called Monmouth Medical Center, which is affiliated with Drexel University. Had a wonderful time there in New Jersey. Spent some time in New York as well, training at Memorial Sloan Kettering.
Oh,
I did
over on the east side.
You got it.
Okay.
You got it. Yeah, trained as well as in the inner city at Newark, Beth Israel. And so I had a very robust, interesting training experience. From there, I did my fellowship at the University of Florida up in Jacksonville, where I was trained specifically in minimally invasive procedures with an emphasis on the minimally invasive management of cancer. And I stayed on there for several years and as an assistant professor before finally coming down to Sebring to join the team down here.
How did you decide to become a surgeon when you have choices when you're going through medical school?
You know, there's a saying in surgery, which is that you don't choose surgery, it chooses you. And I think that's...
I've never heard that when I've been on the table. The only thing I've heard when I'm on the table is you have been chosen.
Yeah. You know, I think there's certain aspects of my personality that just catered to surgery. One is that I love talking to people, I love being around people, and I love to help people. But I'm also a mechanical person. I love engines, I love cars, I love working with my hands. And so surgery is kind of the perfect meld of those two things. Add in a little bit of art loving, and you get a perfect mix with surgery.
So what kind of surgery do you specialize in?
So I specialize in laparoscopic procedures, specifically for cancers, as well as foregut procedures for things like reflux. So everything that I do for the most part involves very small incisions and the use of a camera, or a laparoscope as we call it, to either remove cancers or to correct other disorders that people have.
You talked about reflux, like acid reflux?
You got it. In fact, one thing that people don't realize is that reflux causes cancer, and it's the number one cause of esophageal cancer. And there's a lot of people out there that have been on medications for a long period of time, and medications often don't work for them. Perhaps they've had procedures like dilations because of reflux. They might have a big hiatal hernia, which is where the stomach actually slips up into the chest and kind of rests behind the heart. And then the medications really don't work, and you have all sorts of other issues like difficulty eating, chest pain. And a lot of people don't realize that can be pretty simply corrected with a very easy, almost outpatient procedure using very, very small incisions. And we've been doing that now for many years. And what we're able to do is basically bring the stomach back down into the chest where it belongs, and then make a new valve which keeps acid out of the esophagus, which is the reason people have reflux. It's basically just a broken one-way valve. Acid that's supposed to be in the stomach goes up into the esophagus, irritates it, and causes all the quintessential reflux symptoms that you read about, like heartburn and regurgitation, difficulty swallowing, and a host of other symptoms.
And so is it correct to assume that acid can create cancer?
Right. So what actually happens is the acid damages the mucosa, which is the inner lining of the esophagus.
Like a mucus?
Right.
Like,
The cells of the stomach are different than the cells of the esophagus. The cells of the stomach are designed to handle acid, designed to digest food. The cells of the esophagus are not. And so when that acid continually burns the esophagus over and over, if you've ever burned yourself on your hand maybe several times in more than one place. You notice each time you burn it, it looks a little bit worse, scars a little bit more. And that's exactly what happens in the esophagus. And those cells then begin to slowly transform into different types of cells. And that's in essence what cancer is cells behaving in a way that they're not supposed to. And that can result in cancer.
385-9985 is our number here on the Medical Hour. 385-9985 on News Talk 730. And I'm Peter Bloom with Michael Latzko, a board-certified fellowship-trained general surgeon, and Kat Muse, office manager, as well with the Florida Hospital Heartland Medical Center. So how long does that surgery actually take to put in a new? You put in a new valve, right?
That's correct. In simplistic terms, that's exactly what we're doing. Is we're correcting the broken valve, putting the stomach back where it belongs, and potentially making a new valve as well. And that surgery, it's not a very long procedure, to be honest. Sometimes it takes about an hour. Sometimes it takes an hour and a half. Now, I just did a lady about a little while ago who had nearly her entire stomach and some other organs up in her chest as well. This takes a little bit longer. It might take 3 hours or so. However, even that patient went home in about a day because, again, the time that you spend in the hospital is largely determined by the pain that you have after surgery as well as the potential complications. And by doing surgery with small incisions, doing it minimally invasively, then people can get out of the hospital quicker. They have a less chance of infection. They have much less pain. And in essence, the goal is get you back to what you want to do, because most people think about surgery as this big, dramatic, horrible event. And it really doesn't have to be that way. And times have changed quite a lot, and our technology has gotten so good that many procedures that people used to be in the hospital a week for, you can now go home the same day from.
It's amazing. Now, I think it's also important to let everyone know that because you have acid reflux once, you're not getting cancer, right?
Thanks for clarifying, Peter.
Okay.
Thanks for clarifying. You're absolutely right, and we don't want to scare our listeners in any way, shape, or form.
It's got to be chronic, is what
It's
you're
got to
saying.
be chronic. Acid reflux that bothers you one time after a burger once a month is not the patients that we're talking about. The patients that need to be concerned and the patients that would want to come see me is maybe somebody who's had reflux for 5 to 10 years. They've been on medications for a while.
Okay.
They've seen their doctor. They've been on a medication for a year. The medication didn't work. They may have something called Barrett's esophagus, and that's one of the key terms that we look for. Once the esophagus has developed Barrett's esophagus, that's the beginnings of change that can turn into malignancy. And so those are the types of patients that I look to help, because yes, as I said, surgery doesn't have to be invasive, but if we don't have to do surgery, we'd prefer not to do it. And 90% of patients can be managed very well on proton pump inhibitors. And we have some really good gastroenterologists here in Sebring that I partner with, and they do a great job of keeping those reflux patients off the operating table. So
It's amazing. It is amazing. We'll be right back. Peter Bloom here on News Talk 730's Medical Hour, and I'm talking with Dr. Michael Latzko, a board-certified fellowship-trained general surgeon, and Kat Muse, who's going to be joining him as office manager at Florida Hospital's Heartland Medical Center. We were talking about acid reflux and how we can, if we've got it chronically, and how it could cause cancer down the road, but it's got to be a while that you've had it, like 5 or 10 years, and
That's
medication isn't working anymore,
that's correct.
right?
Yeah.
So that's a big one. What else? What other surgeries do you do a lot of?
So I do a lot of cancer surgery, colon cancer, stomach cancer, small bowel cancer, pretty much every GI malignancy that you think of, pancreatic cancer as well. And the goal is, again, to provide treatments for these cancers that achieve the same purpose that open surgery does, but do it with smaller incisions, do it with less hospital time, and do it with in a way that will help the patients recover quicker.
385-9985 is our number here, 385-9985 on News Talk 730's Medical Hour. You're talking about pancreatic cancer. There was a time when if someone had pancreatic cancer, they were doomed.
Yeah.
And that's not the case anymore?
Well, pancreatic cancer is a really, really tough one, and it's still one of the more aggressive cancers that's out there. However, One of the nice things about current technology is that we've got a lot better with our CT scans and our MRIs. Also, our GI doctors, and we have an excellent GI doctor here in town who does procedures called an endoscopic ultrasound. And these endoscopic ultrasounds enable us to get a very close look at certain pancreatic masses, perhaps even get a sample of these that may tell us early on if this is a lesion which is at risk of cancer or a lesion which already is cancer, and ideally address that tumor early on. Pancreatic cancer is still an aggressive tumor, but it's not, as you said, does not have to be a death sentence immediately anymore. No.
You talk about taking like a biopsy, a sample.
That's correct, yeah.
Now, I've heard, and I'm sure others of our listeners have heard the same thing, that if you pierce in doing a biopsy, it can spread faster. Is that true if it's cancerous?
Well, actually, it turns out that isn't really true, and it's there's many common misconceptions about cancer, and that's certainly one of them. That if you biopsy the cancer, that you're at risk of having the cancer spread sooner, but that's not true. In fact, I think one of the most common cancers that I want to talk about is colon cancer. And the way colon cancer is biopsied is through a routine screening called a colonoscopy. Mm-hmm. And if you're over the age of 50, you should have one. If you had a family member who died of cancer or got colon cancer at a younger age, you should have one even sooner. And the reason is because colon cancer starts as polyps. These polyps can be removed through a colonoscopy or an endoscopy, and they can either detect cancers before they've spread, or they can remove polyps before they become cancer. And so if you haven't had a colonoscopy, go see your gastroenterologist, get one done because it could save your life. And the biopsies of those masses are not going to cause the cancer to spread sooner.
Okay.
Now, there are certain cancers, certain tumors that we don't want to biopsy. And that's why, this type of work needs to be done by a medical professional. And so when you come see us, we'll make sure that you get the right care for the right type of cancer or tumor, or even just screening that you need.
So you can spot a tumor and know if it's cancerous right off the bat, some of them.
Well, we always take biopsies and we want to look at the pathology to confirm. Certainly, with experience, you learn to recognize the appearance of certain things either on CAT scan or their appearance on a colonoscopy or an endoscopy, and you can be pretty much certain of what the biopsy results are going to tell you. However, we always wait for that final pathology to tell us exactly what's going on in these cells.
How long does that take?
Typical pathology report takes between 7 and 14 days to come back.
Why?
So, well, it's a complex process. It's not as simple as you think. The cells are sliced up into tiny little layers. They're dyed with all sorts of different dyes. In addition to that, we send off immunohistochemical markers that are basically different things that bind to different cells or stain them different colors. And a pathologist's job is quite difficult. If I showed you two different slides right now and asked you which one was cancer, I guarantee you wouldn't be able to get it. In fact, I might not be even able to get it. However, a trained pathologist...
Well, then I feel better.
A trained pathologist, that's why we have them. And that's why medicine has become so specialized. Because with the broad scope of medicine, each individual doctor has his role to play in his field. And that's why what I do is important, but what my team does is even more important. And I have a host of wonderful people that I work with at Florida Hospital. Florida Cancer Specialists that has a wonderful group of oncologists, Dr. Ahmed, Dr. Shaw, Dr. Yellow, just to name a few, Dr. Riaz. We have Dr. Bollinger, who's a wonderful radiation oncologist. We have a wonderful...
We've had Dr. Bollinger on the air.
Oh, you've had Dr.
Yes.
Bollinger. Perfect. Great. So you know what a wonderful guy he is.
Yes.
And the mission that he's doing. I partner with wonderful GI doctors, Dr. Avalos, Dr. Patel, Dr. Akichi, Dr. Thacker, and all these guys. We all work together to make sure that each person does his job well to make sure that the patients get the right care, because a good team is never about one person being greater than the rest of the group. And at Florida Hospital, we believe firmly that, our care is really only as good as our team and not as good as a single individual member.
And there's no I in team.
There's no I in team. You got it.
385-9985 is our number here at the Medical Hour. I'm Peter Bloom with Michael Latzko, board-certified fellowship-trained general surgeon. Give us a call if you've got some questions for the good doctor here. It's really fascinating. You were talking about colonoscopies before.
Right.
And you should get them. Rule of thumb is typically, if you're 50 years old, it's every 5 years after that.
Yeah,
right?
typically, and they may move the age even earlier because I can't tell you how many times, and it's sad, it breaks my heart that I see somebody at age 45 diagnosed with colon cancer. And that doesn't mean that if you're 30 or 35, you need to go out and get a colonoscopy right away. It means you need to talk to your medical doctor about what your risk is, and that's a complex subject. I could spend 3 different medical hours talking about just what all the different risk factors are for each cancer.
We'll have you come back.
We'll have me come back. So that's what you talk to your primary care doctor about. Here's what my medical history is. What's my risk of cancer? When should I get my screening? However, if you're over age 50 and you haven't had one, then now's your time to go speak to your gastroenterologist, because pretty much as a general rule, somebody over the age of 50 should be looking at having a colonoscopy very soon if they haven't had one.
Are polyps pretty much chronic in men, especially over the age of 50?
I wouldn't say that they're chronic. What we would say a polyp is it's the beginning of a change in the colon, and certain polyps, if left long enough, can change to cancer. Now that transformation typically takes place over about 10 years, and that's why we say, give a colonoscopy every 10 years, because if you got one and you had no polyps, well then it's probably going to take about another 10 years for you to form a polyp and for that polyp to turn into cancer.
I see.
Obviously those rules change, depend on if you had polyps or what type of polyps you have. But as a general rule, after 50, you want to make sure that you get a colonoscopy.
Okay.
Hi, this is Barry Foster.
I'm Peter Bloom here on News Talk 730's Medical Hour with Dr. Michael Latzko, a board-certified fellowship-trained general surgeon, and Kat Muse, we haven't talked to very much here, both with Florida Hospital's Heartland Medical Center, and you are going to be the office manager.
Yes.
What do you do now?
Right now I work for Pioneer Medical Center in Wauchula. We're a rural healthcare clinic, and I've been there for 2 years.
Okay. We've had folks on from
Yes,
Pioneer
you
before. And do you know who they were?
Mr. Gill, Mr. Coker.
Yes. Exactly right. Okay. So good to see you're paying attention.
Yes, sir.
And you scheduled appointments around them when they were on the
I
on
did.
with me, right?
I did.
Okay. We were talking about colon cancer, colonoscopies. There's a lot of misconceptions out there that
Right.
people get, and it's because of the internet, right?
Unfortunately, you're right there, Peter. One advice that I give to my patients all the time is that although you may think it's okay to watch a YouTube video and then go change your oil, it's probably not okay to watch a YouTube video or do some Googling and diagnose yourself with cancer and pick out a doctor and decide what type of treatment you've had. So the best thing to do is trust the medical professionals to help make the decision for you.
It's not always pick out a doctor. It might be that they see homeopathic remedies, which may not work.
Right. And it's okay to certainly try out different therapies, but it's important to also listen to your doctor. And if your doctor tells you, look, you need to see a surgeon for this problem, then you need to see a surgeon. And you shouldn't avoid talking to a surgeon because you're afraid you might have surgery. To be honest, I would say over half the people I see don't end up needing surgery. They just end up needing good advice. And that's why I really love what I do, is that, yes, I get to operate on people and get them out of the hospital quicker and get them back to their life sooner. But a lot of times, I just have helpful, good news to give people and send them on their merry way and basically rid them of that fear that they may have had and been carrying around with them for years and years, worrying about a specific problem, whether that be reflux or whether that be a colon polyp or even whether that be something like gallstones.
gallstones or gallbladder cancer, right?
Gallbladder cancer or gallstones. Definitely not the same thing, but gallbladder cancer can be a very serious cancer. Often is discovered when we're taking out the gallbladder for other reasons. I would tell the listeners, certainly not to be worried about having gallbladder cancer if you have symptoms. However, if you know you have gallstones and you're having symptoms, that may be something that we need to address. Symptoms of gallstones or biliary colic or gallbladder disease is typically pain on the right side that occurs frequently after you eat and most frequently after fatty meals. Sometimes it'll radiate through you to your back. And again, that's treated with a very simple outpatient laparoscopic procedure, meaning you come in the morning, you go home in the evening. Now, that's assuming we address it at the right period of time. So,
is that taking the gallstones out, or is that taking the whole?
Well,
gallbladder
we take the whole gallbladder out. It turns out there's no safe way to just remove the gallstones and treat the disorder. In addition, if we did that, they'd be back eventually. Gallstones develop as a result of an improper balance of different fats in the body's blood, and so they dissolve in the gallbladder and precipitate into stones.
So ultimately, you're going to get them back if you've had them once.
Ultimately, you're going to get them back unless we take out the gallbladder. Yep.
Well, then let's go right for taking the gallbladder out. Sounds like it'd be the best way.
Right. Now,
you're not going to have the problem again, right?
I'm glad you brought that up. Let's talk about that, because you might be one of the 90% of people out there that's been told they have gallstones but doesn't actually have symptoms. Now, in that situation, we actually don't do anything. And that's kind of the old adage of if it ain't broke, don't fix it, which about 75-80% of people, when they die, if you opened up their body and you looked at the gallbladder, they'd have gallstones. But obviously, a very small fraction of those have symptoms. So what we say is, just because you heard you have gallstones one time on an ultrasound or a CAT scan or an MRI does not mean you need surgery.
Doesn't mean it's problematic.
Doesn't even mean it's problematic. Okay, a lot of people have gallstones. However, if you have the symptoms that I just mentioned, pain on the right side after eating fatty foods, radiates to your back, often associated with nausea and vomiting, then that's a different story. That's something you should probably come see your surgeon for and have us take it out before it becomes a more serious problem where your gallbladder can become gangrenous, which I know has happened to some people.
It certainly has. I know people that have had a gangrenous gallbladder. 385-9985 is our number here on the Medical Hour on News Talk 730. I'm Peter Bloom with Dr. Michael Latzko, a board-certified, fellowship-trained general surgeon. Just quickly, board-certified. What does that mean exactly?
Well, basically what that means is after a surgeon has completed 5 years of residency training, in addition to the medical school training and all the other training that we go through, there's a very rigorous process in which there are written and oral exams that a surgeon has to pass, along with a host of other qualifications that you have to make sure you meet in order to be considered board certified. And the American Board of Surgery takes a very rigorous stance on this, and they put you through the ringer in terms of the tests that you have to go through orally and written to make sure that you have the adequate surgical knowledge to be certified by the American Board of Surgeons as a surgeon.
Does that also mean then that they want to see you operate in the operating room?
That's correct.
Right? Because they want to see that you can do it. It's not just written and oral.
Well, yeah, you're absolutely right. You have to prove with information that you've done a certain amount of each specific type of case that they've lined up, and there's certain cases that they look at that you have to do more than others, and you have to prove that you've been able to do all these cases successfully, and you have to have other people that have witnessed you do those cases. And as if that's not enough, you have to maintain that certification on a yearly basis, and there's tests that you have to take every certain years. There's additional education that you have to maintain, all in order to maintain your certification as a board certified general surgeon. So it's not a passive process where once you pass the test, you're good for life. It's something that has to be maintained. So you got to stay current with the current technology, with the current literature that tells surgeons what to do. And it means you also have to stay continually practicing.
385-9985 is our number here. Coming up next on News Talk 730, we're going to be talking a little bit more about different organ parts and cancers and how we're going to fix that.
Play direct discount 385-5689.
I'm Peter Bloom here on News Talk 730's Medical Hour. Our number is 385-9985. That's 385-9985. I'm talking with Dr. Michael Latzko, board certified and fellowship trained general surgeon, and Kat Muse, who is at Pioneer Medical at the moment and is going to be moving over to Dr. Latzko's office towards the end of November at Florida Hospital's Heartland Medical Center. Boy, that's a lot to say, isn't it?
It's a mouthful.
It is.
And Florida Hospital will soon be Advent Health, which is not any less of a mouthful, but I think a couple of...
yeah, it's a few less words.
A few less words.
And syllables.
Syllables, yeah.
Yes. So we were talking, when we went into the break, we were talking about all the literature you got to stay up on, and you were saying that you're actually going up to Boston next week.
That's correct. One of the questions that Peter asked me during the break, which the listeners may have missed out on, is how in the world, if I'm operating all day long, every day, and seeing patients in the hospital, do I stay up and stay current on the literature? And there's a lot of ways we do that. One is by reading a little bit every day as I go along, and as certain literature pops up, it pops up on my phone, pops on my email, and I make sure that I read that. The other thing is that I try to stay active in a community with other surgeons, and that's really important because that way I get to see what other surgeons are doing all across the country, and I get to look at their data, compare it to mine, make sure that I'm doing the best job that I can do, and learn from their mistakes and also learn from their successes. So next week, actually, I'll be heading up to Boston to go to the American College of Surgeons meeting, where I'll get to hear hundreds of different surgeons speak and present data on the latest approaches, the latest treatments for a host of different surgical conditions.
So do you have, I guess surgeons are coming from all over the country?
Absolutely, not just all over the country, but all over the world. This is, the largest surgical congress that takes place. It's the American College of Surgeons Clinical Congress. And yeah, we have people come in from all across the globe, both to learn from us, but also to teach us.
That's amazing. And you can get it all in 4 days.
Well,
yeah,
I do my best.
Right?
You get as much as you can, Peter.
You're taking a lot of notes, right?
Oh, absolutely. We take a lot of notes, and everything's videoed. We bring that home. I typically bring the PowerPoint presentations home for myself. And it's a meeting that I've presented at myself several times before.
Oh, you have?
Yeah, absolutely.
Oh, okay.
Yeah.
So you're a speaker as well as a listener.
This year I won't be. This year I'm going to focus on just taking things in for myself. But I have spoken there before, presented videos that I've done of surgeries, perhaps rare surgeries or rare managements of unique conditions, to get everybody's take on, is this the best approach, or is everyone doing it this way? Could we be doing it any better? And I've also spoken on a couple of different topics, presented posters and things like that over the years. And I think that's a great idea for surgeons, because it just makes sure that, again, you're comparing what you do to everybody else out there to make sure that you're providing the highest standard of care to all of your patients. I think of every single one of my patients as one of my family members, and I wouldn't do anything for one of my patients that I wouldn't do for my mother or my father.
That's a great attitude. That's a great attitude, and it's comforting to know that. We were talking before about gallbladders and gallstones and also gallbladder cancer.
Right.
And clearly you can have the gallbladder removed and there's no issue.
That's correct.
But how about the stomach? You can't remove the entire, well, I guess you can remove the entire stomach, but it's not optimal, right?
Well, that's an interesting thing. This topic is a little bit more complex, so I'll try to keep it as simple as I can for our listeners, which is that when people have stomach cancer, we can remove part of the stomach. Sometimes we have to remove the whole stomach. And essentially what we do after that is we construct the digestive tract. And there's many different complex ways to do that. For example, when we have to remove a part of the esophagus, we change the shape of the stomach and we convert that into a new esophagus that we use to replace the esophagus that's been removed. When we have to remove a part of the stomach, we may reconstruct the bowel in a way to act as either a new stomach or a neo-stomach, or just to reestablish the GI tract.
All right, hold on a second. I have a question here.
Go ahead.
Okay, because you were talking about the stomach, and you could take part of it to reconstruct the esophagus.
That's correct.
Okay. However, you said earlier that with acid reflux, the stomach is, the acids that are in the stomach have one different kind of enzyme or whatever, right?
That's correct.
Okay,
yeah.
and the esophagus has another. So now if you're taking part of the stomach and putting it in the esophagus, what precludes you from not having the, right? You know where I'm going with this.
Right. No, I do. It's a valid point. And as it turns out, if you have esophageal cancer, the solution which keeps you alive is the best solution.
Okay.
So,
Yes.
when we remove part of your esophagus, there are limited options to reconstruct that. And as it turns out, the stomach is probably the best one to do that. There have been other parts of the GI tract that have been used, the colon, the small bowel, but typically the greatest success and the lowest morbidity, meaning the lowest number of complications, occur when we can use the stomach to reconstruct the esophagus. And the way that the GI tract is established is completely different, so we don't necessarily run into some of those same issues down the road. Again, if you have esophageal cancer, we got to do what needs to be done in order to fix that problem.
Yeah, because it's not going to get any better without fixing it.
And
right?
you make a valid point. It's never going to be perfect like it was. What we're doing is we're taking a terrible situation and we're turning it into a much better situation. What we're not doing is completely putting you back as a brand new person. It's not like taking out an alternator and putting in a new one.
This is Harlan.
Fairmont Cinema Square in North Sebring, Highlands Jewelers.
I'm Peter Bloom here on News Talk 730's Medical Hour, talking with Dr. Michael Latzko, board-certified, fellowship-trained general surgeon with Florida Hospital's Heartland Medical Center, and I don't want to forget Kat Muse, who is going to be the office manager of the Pioneer Medical Group over in Wauchula right now.
Yes, sir.
And how long have you been there?
2 years.
2, okay. And were you in Sebring or Wauchula area before that, or?
I live here in Sebring.
Okay.
I worked for a physician here in Sebring before I left and went to Florida Hospital.
Okay. We were talking with Dr. Michael Latzko. 385-9985 is our number, about stomach cancers and what have you. Diverticulitis is another thing that we should be talking about, because that's kind of hooked in there as well with the stomach, right?
That's the other end of the tract.
Okay.
So if the stomach was the engine, the colon's going to be your exhaust pipe, and so diverticulitis is a tricky disease. And essentially, what happens with diverticulitis is the colon develops little outpouchings, which is called diverticulosis, and because of just random bad luck most of the time, those little pouches can burst and let little bits of stool out into inside of the abdomen where it's not supposed to be. And this creates an infection or an inflammation, and hence the term itis, so diverticulitis. And just to give our listeners a couple of easy tips to live by, if you've had diverticulitis that had to be drained by draining that pus out with a catheter, then typically we recommend that part of the diseased colon need be removed. Also, if you've had multiple episodes of diverticulitis, we say more than 3, then that part of the colon should be removed. And here at Florida Hospital, we offer the latest techniques in terms of dealing with that disease process. And what that means is minimally invasive surgery, small incisions to remove that diseased part of the colon, make tiny little incisions to get it out, and get you back to your life as soon as possible.
But then you got to stitch it back or plug it back up, right?
You got it. So we remove a part of the colon and put it back together. And actually, I'm glad you brought that point up, because one of the things that can happen is that if we don't remove that section of the colon that's perforated already and had an abscess that needed to be drained, or has perforated many, many times before on a small scale, and if we don't deal with that in the right way, then you can end up with a terrible episode of diverticulitis where you actually can't hook back up the 2 ends of the pipe. And in that case, we have to do something called an ostomy, where the colon's brought out through an opening in the skin, and you got to wear a bag, either temporary or permanent. Colostomy bag. Nobody wants that. I don't want that for any of my patients. Nobody wants that problem. Sometimes we have to do it because the situation mandates it to keep you safe. However, if I can get to those patients ahead of time at the right point in time, then we can remove that colon with small little incisions, get you out of the hospital in a couple of days, and get you back to your life.
Is there a difference between diverticulitis and inflammatory bowel disease?
Yes. Diverticulitis is the disease process that I mentioned, where you get a small little perforation of one of the diverticula, an outpouching of the colon that causes inflammation of the colon. Inflammatory bowel disease is kind of a broad term that's given to a couple of different diseases, primarily Crohn's disease and ulcerative colitis. And these are inflammatory diseases that can affect, in ulcerative colitis, often the entire colon. In Crohn's, it can affect the entire colon, and it can affect the small bowel and stomach as well. And so these are inflammatory diseases within the inside of the colon itself, as opposed to a perforation outside of the colon. Now, Crohn's and ulcerative colitis, if it gets bad enough, can also lead to a perforation.
Well, now colitis is more than just a car crash.
Colitis is more than just a car crash. You got it.
Okay. I'm Peter Bloom here on the Medical Hour, and coming up next on News Talk 730, I'm talking with Dr. Michael Latzko. We are going to talk about bile duct disorders.
The automotive event of the year, 00196.
I'm Peter Bloom here on News Talk 730's Medical Hour, and I'm talking with Dr. Michael Latzko, a board-certified, fellowship-trained general surgeon with Florida Hospital's Heartland Medical Center and Cat Muse office manager to be, or not to be. No, you will be to be at the end of November.
She will.
Yes, sir.
Right. At the moment, you're with Pioneer Medical Group. I want to talk a little bit about bile duct disorders. And what is that exactly?
Well, there's a whole different constellation of bile duct disorders. Perhaps the ones that I think I want to talk about are biliary strictures, choledochal cysts, and common bile duct stones. So to summarize what those three things are, common bile duct stones is when a stone comes out of the gallbladder and gets stuck in the common bile duct, and we can either remove that through surgery when I take out the gallbladder, or I can ask for my colleagues in gastroenterology to help remove that stone a different way through something called an ERCP, and then we work together.
What does that mean? Because that's an acronym.
That's
right?
an acronym, you're right. And basically, I'm not going to say the whole name because our listeners will be writing it down for a long time. But basically what it means is we go in through the mouth and pull the stone out from the other end of the duct. In surgery, I pull it out from the end where it came from, which is the gallbladder duct. And either one of those techniques or a combination of those techniques is what we use for common bile duct stones. Common bile duct strictures is something that can result as a result of previous surgery, where there's an injury to the bile duct and it strictures down. It can also stricture down because of benign disorders or things like cancer even. And typically the way we get around that is to hook the small bowel up to drain into a healthy area of the common bile duct. And again, we like to do that with laparoscopic or minimally invasive surgery whenever it's possible to minimize the amount of time the patient spends in the hospital. A choledochal cyst or a bile duct cyst is a genetic condition you're born with, and it sometimes causes symptoms, but it's often just picked up on an MRI or a CT scan or an ultrasound. And the reason we deal with those is because most cysts lead to cancer down the road, at least most biliary cysts lead to cancer down the road. And so we reconstruct those and deal with those in the same way by getting rid of the cyst and hooking up a healthy area of the bile duct to drain back into the bowel like it's supposed to.
You know, you've been really informative today. And
Thanks,
I guess as a listener, I'd be asking myself, why would I want to be treated at Florida Hospital's Heartland Medical Center?
Yeah, that's a great question. One of the reasons I'm happy to come on your show is that it's really been a pleasure and an honor working for Florida Hospital. It's been certainly the best organization that I've ever had the pleasure of working with, and that's for several reasons. Number one, at Florida Hospital, soon to be Advent Health, we emphasize the importance of team. And that means no one single part is greater than another. We all work together as a team to make sure our patients get the best care possible. In this day and age, you really need often many doctors to work together to enable you to get the best care possible. Number two, we have the latest and best in terms of medical technology. That means that I can perform your surgeries using the highest def screens, 4K cameras, and highly detailed imaging to help me see what I'm doing and to help get your pathology out and help get your condition treated. The final thing I'll say is that, with Florida hospitals soon becoming Advent Health, the organization's only going to be stronger because now we're going to be uniting a whole group of different hospitals in a different way to hopefully make your records available to all different doctors, as well as to, again, create a bigger team of people that can all work together for you.
Patient experience.
Yes, for the whole patient experience. Often people think that if you go to the biggest hospital in the biggest part of the country that you're going to get the best care. And as it turns out, that's not exactly true. Here at Florida Hospital, I think we can offer a better patient experience than a lot of places because we have an approach that's tailored to each patient. We consider each patient individually. You're not just a name and a number. You're not patient number 642 of the day. I know all my patients' names. I know what kind of diseases they have, and I work together with my team on the phone every day to make sure each patient gets what they need.
Well, I thank you, Dr. Michael Latzko, board-certified, fellowship-trained general surgeon with Florida Hospital's Heartland Medical Center, and talking with Kat Muse, office manager at the moment with Pioneer, soon to come over to work with Dr. Latzko. I want to leave this thought as well. Here's another reason to go to Florida Hospital's Heartland Medical Center. They have a rated A for excellence, and that's important too.
Absolutely.
You're absolutely right. Thanks for mentioning that, Peter. There's so many great things. I'm sure we can't get to them all in this show, but safety is paramount, and Florida Hospital has been rated grade A.
Okay.